Our third speaker is Dr. Tomonori Ishikawa, and he's now Dr. Ishikawa is from Tokyo Medical and Dental University, and Dr. Ishikawa received his medical degree in the same university in 1997, and he also obtained a PhD in the same university in 2006. And Dr. Ishikawa has been through the assistant professor, and right now he's the associate professor in Tokyo University, Tokyo Medical and Dental University, Graduate School of Medical and Dental Sciences, Department of Pediatrics, Perinatal and Maternal Medicine. Dr. Ishikawa will present the personalized ET improves implantation rate in patients with recurrent implantation failure. Okay, Dr. Ishikawa, please.
Okay. Thank you for kind introduction, Dr. Andy. Good afternoon, everyone. I'm Tomonori Ishikawa from Tokyo Medical and Dental University. Today, I'd like to talk about our personalized embryo transfer study for women with recurrent implantation failure. First, I will show you the current ART treatment in Japan, then window of implantation and ERA test. Lastly, our retrospective study for recurrent implantation failure with personal embryo transfer. Let's get started. In Japan, all ART clinics and hospitals register cycle-specific information for all ART cycles, including patient characteristics, information on ART treatment, pregnancy, and obstetric outcomes. The trends in the number of registered cycles for IVF, blue bar, C, orange, and frozen solid embryo transfer cycles, gray, from 1992 to 2017 are shown. Since the introduction of the public subsidy system in 2004, the ART cycle in Japan has increased dramatically. In 2017, about 450,000 ART cycles were provided at 600 ART facilities. As the number of ART cycles increased, so does the number of babies born with ART. In 2017, more than 54,000 neonates were born with ART treatment. This means 1 in 18 was born by ART in this year. Another notable point is that 85% of babies born with ART were due to the FET cycle. As fresh cycles with freeze-all embryo have increased, the embryo transfer cycles have shifted from fresh to frozen cycles. The distribution of the registered cycles with embryo transfer, clinical pregnancy, and live birth for each age are shown here. You can see that women around 40 years of age are the most common patient of ART treatment in Japan. Here is the rate of pregnancy, live birth, and miscarriage by patient age in 2017. The pregnancy rate per embryo transfer exceeded 40% up to 35 years of age and gradually fell around 30% after 39 years of age and below 10% after 44 years of age. The live birth rate per registered cycle was around 20% up to 34 years of age, and it decreased to 9% by 40 years of age and 3% by 43 years of age. The miscarriage rate per pregnancy was 70% for those who were under 32 years of age, and it gradually increased with an increase in patient age. And then it was 34% for those who were 40 years of age. In 2008, Japan Society of Obstetrics and Gynecology, JSOG, recommended restricting the number of embryo transfers to 1 in order to prevent multiple pregnancy, but double embryo transfer was allowed for women who were older than 35 years of age or women who have experienced repeated implantation failures. In 2017, single embryo transfer was performed at a rate of around 86%, both for fresh and frozen cycles. After the restriction of number of embryo transfer, multiple pregnancy rate has decreased from 11% in 2007 to 3% in 2017. As I mentioned so far, based on the JSOG ART registry data, the increasing age of women undergoing ART is a major problem in Japan. Therefore, aneuploidy of embryo is of greatest concern. Thus, there is a high expectation for PGT-A. In addition, the widespread use of freeze-thaw technology and single embryo transfer may contribute to the effectiveness of PGT-A. And this year, JSOG just started clinical trials for PGT-A. The targets are recurrent implantation failure, recurrent miscarriage, and chromosomal rearrangement. This is a result of JSOG pilot test for PGT-A conducted since 2017. In PGT-A group, indeed, the clinical pregnancy rate per embryo transfer and live birth rate was significantly improved by 71% and 62% respectively, suggesting the effectiveness of PGT-A for recurrent implantation failure. However, consistent with other reports, the pregnancy rate and live birth rate is only 60 to 70%, even after transferring a euploid embryo, suggesting a factor other than the embryo is associated with the establishment of pregnancy. It is endometrium. Endometrial factors include window of implantation, chronic endometritis, anatomic abnormalities such as mucosal fibroid or endometrial polyps, and immunology. The concept of window of implantation was introduced in 1950s. Histological evaluation has been used for endometrial dating. However, its accuracy and significance as a predictor of endometrial receptivity or evaluation for recurrent implantation had been controversial. So far, no accepted formal definition was made for recurrent implantation failure. Here is some definition from recent papers. After 3 failed IVF-ET cycles with good quality embryos transferred, or after 3 unsuccessful cycles of IVF with 2 embryos of high quality, or the failure of clinical pregnancy after 4 good embryo transfers with at least 3 fresh or frozen IVF cycles in women less than 40 years old. There is some treatment option for recurrent implantation failure. And also you can see the term personalized here. And ERA is also here. Endometrial receptive analysis ERA was first published in 2011 in order to create a genomic tool composed of a customized microarray and bioinformatic predictor for endometrial dating to detect pathology of endometrial origin and to define the transcriptomic signature of human endometrial receptivity. This molecular diagnostic tool uses NGS to analyze the expression levels of 263 genes associated with endometrial implantation, such as immune response, response to stress, external stimulus, wounding, receptor binding, cell invasion, and cell signaling. The ERA tests have been demonstrated to be highly sensitive and specific in detecting gene expression profiles associated with implantation potential. This slide shows the timing of endometrial biopsy and window of implantation, both in natural cycle and hormone replacement therapy cycle. Window of implantation is usually at P+5. When the biopsy was done here, it is receptive. When window of implantation is backwards, the answer is pre-receptive. On the contrary, window of implantation is forward, it is post-receptive. Here is the ERA test result report. Sorry for Japanese version. The result of the analysis were reported as receptive. Therefore, it is recommended to transfer a blastocyst at the same time with the same hormone replacement therapy cycle as the ERA test. The following are the results for early and late receptive, which are classified as standard region. For early and late receptive, 12 hours later or earlier, embryo transfer is recommended respectively, with the same hormone replacement therapy cycle as the ERA test. For pre-receptive 1 day, 24 hours later embryo transfer is recommended with the same HRT cycle as the ERA test. For pre-receptive 2 days, and post-receptive, another biopsy is recommended. Since the first publishment, more than 20 papers about ERA have been published already. And this is the latest paper on window implantation. They characterize the transcriptomic transformation of human endometrium at single cell resolution across the menstrual cycle, resolving cellular heterogeneity in multiple dimensions. Then they discovered that the human window of implantation opens with an abrupt and discontinuous transcriptomic activation in the epithelium, and then accompanied with widespread digitalization feature in stromal fibroblasts. This is a result of a global ERA test obtained by analyzing 9,000 cases from 70 countries. The percentage of receptive was 43%, and the percentage of standard lesion that included up to 12 hours before and after receptive was 69%. The ERA test result from 9,000 Asia-Pacific patients, including 700 from Japan, were similar to the global result, with 44% receptive and 67% standard lesion, indicating no regional differences. When Igenomix Japan was founded in 2017, they accepted 10 ERA test cases per month, but now accept 700 specimens per month from over 250 ART clinics. According to the latest report, more than 100,000 endometrial tissues from greater than 2,000 ART clinics in over 80 countries have been analyzed for ERA tests. Moving back to Japan, the distribution of age who took ERA test was shown here. Similar to the ART data registry, there is a high percentage of older women. The following are the results of the ERA test in Japan through June 2020. Like the overseas data, 44% of patients were receptive and 68% were in the standard region. However, more than half of the patients were recommended to have their embryo transfer times modified. This graph shows the distribution pattern of ERA tests by age. As age increases, the percentage of receptive gradually decreases, while the percentage of pre-receptive is increased. Then I will show two literature about personalized embryo transfer. First one is from Kyoto Art Clinic, Japan. which is published in 2017. This is a retrospective study for personalized embryo transfer for repeated implantation failure. Higher-aged 50 women who had a history of repeated implantation failure with at least 3 good quality embryo transfer took ERA test. The 24% of the patients with recurrent implantation failure were non-receptive, and pregnancy rate after first personalized embryo transfer in non-receptive group was 50%. All the pregnant cases of the non-receptive groups achieved pregnancy in their first personalized embryo transfer, suggesting that ERA test and personal embryo transfer were effective for a subset of patients with unexplained recurrent implantation failure. Another study is prospective randomized multicenter international open-label controlled trial. Patients undergoing IVF at the first doctor appointment were allocated to 3 groups. 148 were allocated to personalized embryo transfer, 154 to frozen solid embryo transfer, and 156 to fresh embryo transfer. Primary objective of this study were live births and cumulative live birth rate at 1 year follow-up. In intention to treat analysis, cumulative pregnancy rate was significantly higher in the personal embryo transfer group versus frozen embryo transfer and fresh embryo transfer. By per protocol analysis, pregnancy rate was significantly higher in personal embryo transfer group vs frozen embryo transfer. And cumulative pregnancy rate was significantly higher in the personal embryo transfer group vs frozen embryo transfer and fresh embryo transfer. And also cumulative live birth rate was significantly higher in the personal embryo transfer group, indicating that evidence for the potential of using a personalized diagnosis of endometrial factor in the workup of the infertile couple at the first appointment. Lastly, I will talk about our study. The result of 93 cases who underwent ERA test with the same hormone replacement protocol from 2016 at Kameda IVF Clinic are shown. 29% was non-receptive. This is same as Japan data. The order was receptive, pre-receptive, and early receptive. Between these two groups, there were no significant difference in age, history of implantation failures, number of previous pregnancy and delivery, body mass index, endometrial thickness, and chronic endometritis complication rate. Next, let's move on to our personalized embryo transfer study. This is a retrospective study. 226 cases who had 2 or more implantation failures were enrolled. ERA tests were explained to them, and whether or not to take ERA test depended mainly on the patient's choice. Clinical pregnancy rate at the first embryo transfer with expanded blasts, that means personalized embryo transfer or standard frozen embryo transfer, was compared. Furthermore, the cumulative pregnancy rate up to 2 embryo transfer also examined. The patient background for each group is shown in this slide. The mean age was in the 38s in both groups. This is similar to patients receiving ART in Japan. BMI was also same in both groups. The personalized embryo transfer group had a higher number of implantation failures, probably because patients with a history implantation failures are more likely to choose to take ERA test. The result of ERA tests are shown here. Receptive was 51.9%. The standard region, which also included both early and late receptive, was 76%. Again, this was not significantly different from previous reports. In contrast, about half of the cases that were not receptive required adjustment of embryo transfer time individually. The clinical pregnancy rate after the first embryo transfer was shown here. The pregnancy rate in the personalized embryo transfer was 46.3%, which was significantly higher than in the standard embryo transfer group. There was no differences in the number of embryos transferred between these two groups. The cumulative pregnancy rate from first embryo transfer up to second embryo transfer was shown here. As with the first embryo transfer, the pregnancy rate in the personalized embryo transfer group was 45.9%, which was predominantly higher than that of the usual frozen embryo transfer group, resulting in a higher clinical pregnancy. Since ERA and embryo transfer take place during different menstrual cycles, some people are concerned about the reproducibility of the test. Only one paper evaluating reproducibility of ERA tests has been reported so far. Within 2 to 3 years, which is a relatively long period for general ART treatment schedule, the results are consistent among 7 people. Now, this is my conclusion. 20 to 30% of patients with recurrent implantation failure were non-receptive in ERA test. About half of recurrent implantation failure patients require adjustment to embryo transfer time individually. Personalized embryo transfer in patients with recurrent implantation failure significantly improves the clinical pregnancy rate. So this is our idea for ERA indication for recurrent implantation failure, and such as variable embryo, that means decrease ovarian result person, or euploid embryo after PGTA, and also oncofertility patient. I will introduce our collaborator, Dr. Kiyotaka Kawai. He's the president of Kameda IVF Clinic, Makhari. And our personalized embryo transfer study was done at his clinic. Thank you for your attention.
Okay, thank you very much, Dr. Ishikawa. I think we have one question here. Okay, so there's a question asking that with patients having ERA testing, is it possible that the endometrial scratching can, with the biopsy method, because it's endometrial scratching, is it causing any increase of implantation rate? Do you think it may have that effect?
You mean endometrial scratch has some effect for receptivity in ART treatment?
Yes, increase the implantation rate. Do you think it increased the implantation rate?
I don't think so. So far, we have no report about the effectiveness of endometrial scratching.
I see. I think in HRA this year, also there's a research talk about comparing the scratching effect, and they found there's no significant difference from the report. The question also, the same doctor asked another question. Okay, do you think we should include the scratching into the consideration of the study? And in the future trials, the biopsy should be performed on the patients not having ERA testing. Means the control group with scratching.
Only scratching?
Yes. Do you think that needs to be considered, or you think it's not necessary?
I don't think so.
I see. Thank you. Okay. And we have quite a few questions coming up. There's a question, I think this comes from Taiwan, that does your study include a PGTA test in the PET and also the FET group?
No. At that experiment period, PGTA is not allowed in Japan.
I see. So
no PGTA cycle.
Yes, okay, thank you. Okay, and there's another question. There's actually quite a few questions. Okay. There's another question from Japan. Does the result of ERA or the window of implantation can change after miscarriage or after the delivery of baby?
That's a good question, I think. But so far, we don't have such a report. Only one report that I have explained in my presentation is 2 to 3 years. Between 2 to 3 years, the ERA test result was not changed among 7 people.
Yes.
But I think these data was not from after delivery or miscarriage.
Yes, I see. So there's no data or report about this yet. Okay. And there's another question. How do you interpret the test that has no result or inconclusive? How when the result shows no result?
I think no results show some reason. One is very small amount of RNA,
Yeah,
or the sample is too small.
or degraded, I guess.
Yeah.
Yes. Okay. Is there any maternal age maternal age related receptivity by ERA? I think that okay. So this question comes from Taiwan too. Do you think the age can change the window of implantation?
Yeah,
I think that's the question.
yes. As I presented in my slide,
Yes.
from Japanese data,
Yeah.
the increase with age, the proportion of receptive is decreasing. On the contrary, the proportion pre-receptive is increasing.
I see.
With age.
Okay, so that's a very interesting result, showing that with increasing age, the window will shift to a later time.
Yeah.
Okay. Okay, that's very interesting question to see. And also, there's another question asking about the cost effectiveness. Do you think using ERA, because the test costs some money for the patient too, do you think with the ERA test, the patient can save some cost? Or you think the patient may spend more money before getting the first live birth? What's your opinion?
I think it mainly depends on the patient's choice.
Yes.
But our data or another data from Japan and overseas, at least 30% to 40% people has altered ERA result. That means they required embryo transfer time adjustment. So if they do not take ERA test, their embryo transfer may be miscarriage or no implantation. That requires some time and also cost for embryo transfer.
I see. And as you mentioned, there are about 30 to 40% who have a displaced window of implantation. And then for the other 60%, how would you see the meaning of the ERA test for these 60% of the patients?
That's a good question.
We have been asked about this question many times. And usually the doctor will say there are many reasons for the implantation failure.
Yeah.
And usually the answer we provide is that at least you can exclude this reason, implantation window, the window implantation as a reason. So window is not a reason for implantation failure. We should seek for other reasons, other possibilities.
I think after PGTA trial, I was studying in Japan. If some person has a euploid embryo, that means it has a higher implantation potential.
I see.
So after the euploid embryo PGTA result, I will recommend ERA test before the transfer of euploid embryo.
I see.
Because the age of women in Japan is really higher, so they has less euploid embryos in general.
I see. So you recommend to combine the PGTA test with the ERA?
Yes.
I see. Okay, I think we have finished all the questions. Thank you very much, Dr. Ishikawa, and thank you very much for your excellent speech.
Thank you.
Thank you very much.